um, with having Dr. Holt share her screen. Trying to see everyone. Is Dr. Holt on right now? Trying to find.
I'm here.
Okay, awesome. Hello.
Hi.
So we're going to go ahead and have you share your screen for your presentation, and I'm going to do a quick introduction for you, and then we will just jump right in.
All
So,
right, let's see if I can screw this up like I typically do when class starts. All right.
awesome. And
We
I
got
just want to give a little reminder to everyone, during the presentations, please stay muted until the end of the presentation. We will have time for questions at the end. And then at that time, if you want to come off of mute and ask your question, that would be the appropriate time to do that. If you have questions during the presentation and you don't want to wait to ask them, go ahead and just type them in the chat. I'll be monitoring the chat and I can pull those out and I'll ask those at the end, just kind of a collective running total of our questions. So without further ado, I'd love to introduce Dr. Erin Holt, Associate Professor and Department Chair of Applied Health Sciences at Baker University. She has been facilitating learning experience for pre-allied health and public health students at Baker University for the past 7 years. One of Dr. Holt's passions is public health, and through this passion, Dr. Holt plays a pivotal role in preparing Baker University public health students to enter the workforce, preparing to tackle the continuously evolving needs of communities and populations around the world. Dr. Holt earned a Master's of Public Health, Health Promotion, and Policy degree from the University of Missouri, Columbia, and her Doctorate of Education, Professional Studies, Teaching in Higher Education from Delta State University. So, Dr. Holt, I will let you take it away and just remind everyone to please put yourself on mute.
Well, thank you. You make me sound so much fancier than I am. So that's nice. Yeah. So I'm excited. So I'm lucky enough to teach and work with Kelly Cheney. So I don't want to say conned me into this because I really, she asked nicely and I said yes and had a conversation, and it was kind of this, hey, will you present on this information? And a few weeks later, I was like, what am I presenting on again? And then we actually got into the conversation of really what the idea behind this was. I'm in a room with people who know a lot about nutrition, a lot more than I know about nutrition, which is scary since at one time I actually taught nutrition. So we'll keep that a secret. But I'm excited to be here and share some of this with you. This is a topic that has been, thrown around in the public health world for easily for about the last 10 years or so, if not a little bit before. I think it was 2011 when it was specifically finally titled Social Determinants of Health. And so it's an interesting concept, and I often talk to our public health students because I also teach like our social and behavioral class where we talk about, behavior changes and behavior modification. And this is why it's exciting, is because I get to go, but it's more than that. There's so many factors that come into play when we're talking about this. And so it's kind of fun. So some of you may have heard some of this information, all of this information, I don't know. And so hopefully everybody takes home a little bit from this, and if nothing else, maybe it sparks some conversation or sparks some thought as you're working with your clients or you're thinking about how you can integrate yourself into the community a little bit better. So basically, we're going to talk about a few things. We're going to talk about health equality and health equity. Obviously, we're going to cover the social determinants of health. That's the big component. How these determinants actually contribute to different health disparities. One of the things that I tend to, I kind of get bogged down in some of the big, things like heart disease and infant mortality rates and life expectancy and housing issues and even access to healthcare and access to food and all these things. And what's interesting is you all work in a world where what you do spans the whole group, right? It spans everybody. And so it's kind of fun to kind of think about it from that perspective. And we're going to talk a little bit about the health impact pyramid. It's a framework that public health uses or thinks about. Oh, and I left a point off because I did. And then I'm going to give you a couple of background on some policy and practice that have come up more recently. I'm gonna have to see a clock. If I keep checking my watch, it's only so that I don't run over and give you all plenty of time to comment. Now, I will warn you, there's one part in here in the beginning that you can unmute yourself and chat at me because I'm gonna ask a question. So I'm an interactive person. I'm not so good at just speaking at people all the time. So equality simply is where every individual or group of people are given the same resources and opportunities. And oftentimes we talk about it, right? Everybody wants equality. Everybody wants to be treated the same. Everybody wants the same resources and the same opportunities and the same across the board. So what are the challenges, right? So here we go. Unmute yourselves if you haven't, or you can put it in the chat, and I can't see the chat, so somebody will have to read the chat to me, but yeah, here we go, interactive. What's the problem with equality? So I'm going to play a game. I'm maybe age myself a little bit because she's no longer on the TV as much, but I'm going to say, some of you are going to know this. So I'm Oprah Winfrey. I invited you to my favorite things, and I'm giving you a card. So you get a card and you get a card and everybody gets a card. Hey. And so what's the problem with me just saying, you know what? I'm going to give this group of people, everybody in this room, I'm going to give you all a car. Here's your car. Here's the keys. Drive it home. What's the problem with that?
Not everyone needs a car or can use a car.
Not everyone can use a car or needs a car for various reasons. So what might some of those reasons be?
Maybe they live in an area where they use transportation, like they use public transportation, or an urban area, or they don't have parking.
Okay, so viable options right there. What else?
From the chat, someone jumped in with, not everyone can afford to be there to receive the gift.
Not everybody can afford. So now all of a sudden we're just giving it to this select group of people, right? Not even everybody didn't even get to attend. Okay, that's a good one.
More from the chat is insurance, parking, driver's license, taxes.
You guys are so much more forthcoming than, sophomores in college. Because you guys understand what all comes with the car, right? So now we have people who can't afford to pay the taxes. We have some people who don't have a driver's license, let alone we probably have some people who don't even know how to drive, right? Because they live in areas where there's public transportation that they've all used. All of these things. So the problem with equality is giving everybody the same thing doesn't work. So the reality of, and you guys have probably, some of you have all probably heard this, is that equality of all means equity for none, right? And so the idea here is that if we give everybody the same thing, we're really missing out on the resources. And so equity recognizes that each person has different circumstances, and we treat them to meet them, match them to where those circumstances are. So my little graphic here, I didn't make it, but it's cute. I thought that was a cute one. I have different ones that I like to use. This is one of my favorite ones. But as we see from an equity standpoint, if you're looking at it from the graphic, is it allows for us to get people to try to reach an equal outcome, but the reality of it is there's still some unevenness to it, right? And there's still some disparity that comes from it. And so what we want to shoot for, and in public health, we just recently rewrote the essential frameworks. It hasn't even been a year. And health equity has become the center focus for all of what we do in public health. And so it's really an important thing to think about, and understanding the difference between equality and equity. And it's interesting because it's an argument that I even make, as a department chair at the university, when they say, well, this is how much money your department's going to get. So my department has 3 faculty members. My department also has 2 majors. So it has exercise science and public health. We do have a minor in our lifestyle medicine nutrition that Professor Cheney or Kelly is more than great in, and she teaches all those classes and does a fantastic job. And then but we are also the highest number of students versus faculty. So we actually have in our 2 majors about 100 students, which is a large portion of our campus. We're a really small school, so it's a large portion of our campus compared to other departments. And so when they say, well, you guys are getting as much money as this department over here that has like 6 faculty members, but 40 students, and you're going, that doesn't seem fair. I have more need because I have more students. And so we think about this on different levels. And so when you're thinking about it, it's also from a budgetary standpoint. It's everything we think about. We have to think from an equity focus as opposed to an equality focus. So I used this other one with my students and thought it was really interesting, their perspective of, not that anybody's going, oh no, I didn't want that stimulus money, but we have stimulus money, right? That has been dispersed to the general public, and everybody got one check, and then everybody gets another check, and everybody's like, oh, but I remind students that for some people, that check wasn't really needed. It wasn't really necessary. That there's some people that had the money, that whether it was they dipped into their savings a little bit, or they never lost their job, or whatever it was, and they just had the ability to pay for things. And then you've got some people that are getting a $600 stimulus check, but they owe $5,000 in back rent. It doesn't really help them that much. I mean, it's nice to get, don't get me wrong, but it's one of those things that it makes it really, really challenging. So when we think of the social determinants, so this is just a list of them. This isn't giving you any graphic other than this is a list and the general idea of what they are. The thing that we have to continuously kind of remind ourselves when it comes to these is that none of these operate in isolation. So no one person just has an issue from a physical environment standpoint, right? It's typically going to be a lot of these variants. And it's a very complex web of factors that really go into influencing what it is that we choose to do. And so I know that a lot of times when I'm doing health promotions and working with individuals, and we're talking about the change in healthy behaviors, and we're talking about, eating your fruits and vegetables, or we're talking about being more physically active, or we're talking about a variety of different, not smoking. What I'm saying is I need you to work with me on this. And what I don't understand is all of these other factors that are coming into play, because I don't ask the right questions, or I used to not ask the right questions. And so one of the things that we have to understand is we have to be able to ask the right questions to look at this, because behavior doesn't exist in a vacuum. Oftentimes people are influenced by a lot of these other factors, and that's the reason they choose the behaviors that they do. I'm going to say most people wouldn't choose to fall into an unhealthy lifestyle. Most people wouldn't choose that. Most people, it's kind of, this is what's thrust into their life, and this is where they are. Now, to say that, it doesn't mean that there are some people who would say, I don't want to do physical activity. I have one of those in my family. It's my mother. My mother doesn't want to do physical activity to save her life. She just won't do it. Here you have somebody who's exercise science, and she's like, no, I'm not going to do it. And I'm like, fair enough. But my mother does a really good job. She has type 2 diabetes, and she 100% controls it through her diet. She's not on any medication. In fact, now her doctor's like, you're not even like spiking numbers that would consider you a pre-diabetic anymore. She controls it 100% through her diet because she refuses to exercise. And I'm just like, okay, Mom, whatever. So, it's interesting that we don't think about some of these other factors. And so this approach to the social determinants of health was first described by the Rio Declaration in 2011. And I'm going to read you kind of a longer definition, but basically the Rio Declaration stated that health inequalities, iniquities, got to get my terminology right. Health inequities arise from the societal condition in which people are born, grow, live, work, and age, referred to as social determinants of health. So it was the first time that was really said, this is what we're going to call it. These include early years experience, education, economic status, employment and decent work, housing and environment, and effective systems of preventing and treating ill health. So we can think of it in a variety of different ways. And you can go into see all these different sources, and they focus on it this way, and this group focuses on it. But really what it boils down to is you've got individual factors that come into play. And this is where things like awareness and knowledge, people's understanding, individual factors, this is where the biology and genetics comes into play, things that we can't necessarily, this isn't really things that we can change, that we have to, so I like to say they're the workarounds, right? We have to figure out how to include people's biology and genetics into that. The systemic vulnerabilities that can be based on biological factors. This includes things like discrimination. And we're going to talk a little bit more about that. And then personal attitudes and motivations. So the one thing that I continuously go back to when we talk about healthy behaviors and trying to get people to choose healthy behaviors over unhealthy behaviors is, what is their motivation? What's motivating them to make the choice in either direction? So you have social, cultural, and group factors. So this has to do with your peer groups and the influence you have from your peer groups. Cultural beliefs and practices play a role, which I'm sure you all are quite aware of, probably at a higher level than myself. And then we also have level of social support. Social support, as we know, when we're trying to do behavior change, plays a key role in that. We have factors that are socioeconomic or structural. This can be poverty and socioeconomic status. This is going to be your education, your access to healthcare, and then also when you throw in the social stressor, that also includes discrimination in that as well, plays a role. Political factors. So as you can see, we're kind of touching on all of these different areas. Access to health insurance, policies and funding for a variety of health promotion programs, regulations that affect. And so obviously the political factors are more the policy-based look of things. And then we have environmental factors, air and water pollutions, things like climate change, and then natural disasters. And so we have all of these different factors. I mean, we just listed so many, some that are on here, some that are kind of related to these, and everybody's influenced by all these factors in a singular time. Right. So a client walks into your office or into the health department or into, I don't know, as a patient at a hospital, and you're working with them at a hospital or whatever setting you're working at, and you're trying to get them to just make better choices. And what you have to remember is all of this plays a role. All of it plays a role. And we're going to get into a little bit of why this is super, super important. But, let's just say you have somebody comes in. Okay. What's the first thing when you're sitting and talking? Now, here we go, unmute or in the chat. What's the first thing that you kind of want them to, information you want them to give you? I mean, outside of, I'm sure you get okay, I have, I don't know, we'll just use my mom's example, right? The type 2 diabetes, I need to change my diet. I don't know how to do that. What other information do you get from people when you talk to them? This is my lack of knowledge of how you guys do intake and stuff.
So often I'll walk people through how many people live at home, who cooks and prepares the meals, what other symptoms do we have going on, and things like that.
Okay.
Before we talk about what are you eating.
Okay.
Couple things in the chat are food insecure, access to food, barriers to making a change, living situation, money, food availability, food preferences, access to grocery stores, knowledge of cooking.
So how specific do you get with your questions? Like that's where it comes from, right? So you think about, like, let's say access to food. Let's use that one. That's a great one, right? Because depending on where you live, you may or may not have good access to or easy access to the healthier options. So what other questions do you ask pertaining to that access to food?
So people have specific as possible. Open-ended questions are what they usually start with, and then they'll tailor in to get more specific. As part of like my intake, I always ask, have you ever been worried about running out of food? Or like how frequently in the last like month have you been worried about running out of food? And then also ask if they get either SNAP, WIC, they use a food bank, or other sources of like support there.
Okay.
Someone else says open-ended questions. So
how many, I should have created a poll for this. What was I thinking? How many of you specifically say, how do you travel to get your food?
One person says yes, a couple people say no. Some with the older populations, they'll ask. Awesome. Looks like that's all that's in the chat. A good like split between yes and no. But yeah.
But think about that, right? So if you have to travel to get your food and you don't have a car and you have to use public transportation and you only have certain days, or you have to get somebody to drive you, and you only have certain days or times that you can actually travel to get food because it's, 5 miles away, even on public transportation, it's too far to walk. Even if you were just 2 miles from it and you had to carry it back, how often are you going to go and seek out the fresh fruits and vegetables, the access to the whole grains, the access to all of these foods that require the prep and all of this, and you're not going to rely on your more convenient food sources. And so just something as simple as knowing how people travel makes a huge difference in how you talk about that access to foods and how can you problem solve around it. Because if you say, well, you need to go to the grocery store or the supermarket and you need to get, really focus on these things, and they're going, I have access to the supermarket for a major shop, maybe once a month. What do you do? Right. And so these are the kinds of questions that we have to think about. I mean, I knew people when I lived in Nebraska, I knew individuals that the closest, shop, like supermarket to where they could afford, easily afford the fresher options. It was a 2-hour drive. And so they specifically only did it maybe once a month, once every 6 weeks. And so then it's like, well, they've got to have food that can survive that length of time. Obviously then they would use like their local convenience stores or corner markets or whatever to get, the essentials and some things, but it was so much more expensive that it was really, they'd only use it if they absolutely had to for certain things. But they'd have the big deep freezes where they'd buy, a few gallons of milk and throw it in because it was cheaper, but food had to last for 4 to 6 weeks, kind of depending. And so that's a challenge that we have to kind of consider when making these. And that's just one example of it. So I'm sure everybody's heard of Healthy People, right? Healthy People 2020, it's kind of in the wrap-up phase, right? We're analyzing all the data, see how we did, et cetera, et cetera. Well, they've already put the 2030 information out of what we're going to focus on. And so it hasn't really changed when it comes to the social determinants of health and the 5 areas they're kind of focusing on for the social determinants of health. So I actually took it from the 2030 site, stealing not really, right? I cited it, it's fine. And so the 5 areas that the social determinants of health we have to consider. The first one is economic stability. So this isn't really new information. If you know a lot about the Healthy People 2020, they've kind of just updated a little bit of information as they're analyzing all the data. We have 1 in 10 people living in poverty in the United States. I don't think that that's, it sounds really bad and it's really horrible. And we think, okay, so 1 in 10 people live in poverty. That's a lot. And then we have low income, which is different than poverty, right? So low income is 200% of the poverty level, and 40% of Americans live in low income, 40%. So almost half of our population in the United States is considered low income. That's troublesome, right? Because you're also talking about people who are probably less educated. You're probably talking about minority populations more likely. You're talking about lower people who cannot necessarily afford housing or safe housing, the lack of being able to afford health care and healthy foods. And so this is something that we have to think about. Poor health is often an indicator that people are struggling to hold steady employment. One of the ways that public health has started looking at the economic issues around access to financial stability has to do with housing. Housing's become a really big issue. And so housing costs tend to make up the majority of Americans' monthly costs. Many times you're looking at over 30% of someone's income going to housing, whether it's they own their own house or they rent. Any type of property, oftentimes you have over 30% of your income is going to housing. And so that's a cost burden, especially when you're talking about single income households, right? So when you have single income households and you know, a third of the paycheck or a lot greater than a third of the paycheck is going to just paying rent or paying a mortgage or whatever that looks like, that's a cost burden. And so what some of the areas are trying to look, and this one of the policies we're going to talk about is the issue around housing and how do we get affordable housing. The second area is education access and quality. So having access to education is great, but what we want is access to quality education. And so people with higher levels of education, more likely to be healthier, more likely to make better decisions, and are more likely to live longer. They have access to quality education, makes a big difference. Children from your lower income families tend to experience more forms of social discrimination. And if you remember in those social determinants of health, I'm going to pop back real quick, right? Childhood experiences make a huge difference in health outcomes. And so when we think about, you know, being discriminated against simply because your family doesn't have as much as someone else's family, that becomes a burden that a child carries with them. And if you don't think that children understand the stress of poverty, then there are some really cool experiences that you can actually do. The United Way does a really fantastic one where you actually get to experience poverty in a simulation. And it's actually a really cool experience. I've done it a couple of times, and every time I get it from a different perspective and go, wow, I just, you know, just the thought of it. Families with in low income, the children are less likely to graduate from high school. Oftentimes they're asked to take on part-time jobs or take on jobs to help with finances. Less likely to go to college because it's seen as a cost that may not be necessary when the family actually requires more financial stability. And then the stress of living in poverty from a child perspective can actually affect their brain development as well, which may influence their ability to be successful in school at times. Oftentimes we see it in the areas of math and reading. I will say though, part of it's because we study math and reading more than the other areas because that's where our indicators are for our state testing. So I mean, but we know how much math and reading plays a role in overall literacy. across the board in different areas. Access to healthcare and quality. So we still have people who live without health insurance. People who live without health insurance obviously are going to be less likely to have a primary physician, are going to be less likely to go to the doctor when they have ailments, are less likely to have affordable health care. And also a lack of insurance typically means that they are less likely to be able to afford their medication. So if you have a client or a person that you're working with that is on medication, asking them those types of questions about how often do you actually take your medication is really, really important, because I think you guys probably recognize that. But there are many people who are trying to stretch their medications. You hear about people who say, well, I'm going to wait and this time I'm going to do a double dose here, but I'm only going to do it every 4 days or something, right? Or I'm going to do a half dose every day so that the 30-day supply that I get lasts 60 days. And they're thinking of it from a financial standpoint, whereas when they're prescribed the medication, it was from a need standpoint based on their specific condition or disease. So that is something that we have to consider as well, is the medication. And there are ways of assisting people with that. Neighborhood and built environment's a really big one. It's a really big one. And this is one of the things that is really determined upon certain behavior choices. So we have everything from high rates of violence, we have unsafe air or water, we have lack of green space, we have the few safe routes to school. And I don't mean because of the crime rates and everything else, I'm going to throw Ball and Sooty under the bus for just a second. One of the things that we've got people at Livewell Douglas County are working on are safe routes to school. And one of the issues in Baldwin City is that most neighborhoods don't have sidewalks. It's not a high crime issue. It's legitimately a traffic safety issue. And so you have to think of things like that as well. And so if you think about it from a safe route standpoint, we can't get kids to actively transport to school, then asking someone to be able to walk to get their groceries or walk to somewhere is also a problem. So the average distance, so this is fun. I found this and I was like, I didn't actually know this. You guys probably did. Access to food. So the average distance U.S. households to the nearest supermarket is 2.19 miles. So that's on average. There was a research study that came out of Detroit looking at the low-income neighborhoods specifically, and low-income neighborhoods for African Americans they had to travel an extra 1.1 miles farther to the closest supermarket than white low-income neighborhoods. So even then, now we have a race disparity even within the low income. So you add that into what they're already doing, you're looking at the potential of, that plus or minus, the closest supermarket could legitimately 3, 4, 5 miles away in an area where you may or may not have transportation. So kind of what we talked about, transportation is a problem. I do appreciate, because you're right, the rural communities, especially the older individuals living in rural communities. So I appreciate that everybody's like, I usually ask my older clientele, but the reality of it is it should be a conversation that we're asking a lot of clients and just understanding where they're coming from. Social and community context plays a big role as well. This is where we have, the unsafe neighborhoods. The biggest one that we are talking about now when it comes to social and community context is discrimination, because oftentimes it's the history of systemic discrimination and discrimination overall that is causing a lot of these big disparities as it relates to health, which is kind of the next thing we're going to talk about. Positive relationships at home, at work, at school, and community help reduce the negative effects that we see from some of this. So I'm going to kind of take a pause here. I know you guys were holding your questions till the end, but I kind of, if there's something specific to like the determinants of health that I could answer a quick question or two, this kind of a burning question, I'd more than happy to do that now. I feel like I'm just talking. I'm not used to just being the only one talking.
And feel free to unmute and ask your question, or you can type it in the chat.
And if not, we can hold it till the end. I don't care.
I just thought I'd share an interesting experience that I had when I was living in Kansas City. During my internship, I actually did bus stop assessments for people grocery shopping by bus. And that, so basically, if you're familiar, and I think a lot of people here are from Kansas City, so it was bus stops in KCK and then also pretty much like along 39th Street.
Mhm.
So asking people questions about how often they shop, basically like how difficult it is to shop by bus, and then also if they felt safe shopping for groceries. And the amount of people that said that they just didn't feel even like safe shopping for groceries was really mind-blowing. So yeah.
Yeah, I mean, it's something that's so key to access to food that I think we just assume people are going to find a way to get there. You know, when we're talking about, but the reality of it is, if you are, you know, half a mile from a fast food restaurant versus 4 miles away from your local supermarket, you're more likely to travel the half mile if you don't have access to a vehicle or public transportation. And we know that not every area, so if we think about even the Kansas City metro area, not every area has access to public transportation, but we have areas where we have low income. And so if it could be that it's a single car family, but, and so, you know, one person takes it, goes to work, another person's responsible for doing some of the other things. It's a challenge. And I think that it's an area that we tend to overlook a little bit. I mean, across the board, not just saying like, you know, from a nutritional standpoint, I think across the board, it's an area that we don't tend to think about when we're thinking about behavior changes.
Yeah, a couple of comments from the chat. From Sarah, I'm currently reading the book Toxic Charity, which highlights doing more than just handing out charity, but empowering communities to help themselves. I'm still learning about this, but it raises some interesting points. Do you have any perspectives on kind of that avenue of like helping people?
Yeah. So, you know, it's kind of that idea of how can we be effective from a standpoint of what's the most that we can do. So, you know, public health minded individuals tend to rely, if we're going to do the most, you know, from a change, like effective change, we tend to really focus on the need for policy, right? Because you see the most amount of impact from a policy. The problem with policy, as you guys probably know, is it takes so much time and people are in need right now. And so, you know, there's things that different health departments have done and communities have created kind of like think tanks and used each other's resources really well to partner together. I haven't read that book specifically. I kind of want to now to think about. But, you know, if you think about communities that are in the greatest need, it's things like, and especially now with COVID has switched some thinking. So, you know, I know now that there are some food banks that are actually handing out vouchers as opposed to being able to hand out food. And so, you know, you can contribute financially to help create those vouchers that they're working with the local, you know, supermarkets to be able to, you know, safely to where people aren't having to drop off food and do extra grocery shopping. There being a small space. And so I think it's a real challenge to find a lot of different people, but what you want to do is you want to find people that have expertise and bounce off each other to where you can pool resources. I mean, the big idea is pooling resources so that everybody can kind of move up together. I don't know if that completely answers your question. It's kind of an abstract way of thinking about it. But yeah, so that, I mean, that's to me is really key.
Yeah, and another comment from the chat is the that they think affording medication is a huge issue right now, especially for insulin, and just seeing patients that have had like social determinant of health issues and that's negatively impacted their health. How can we support people through that? Because I think getting insulin in particular is like a challenge. Do you have any like
Yeah.
even at like a practice level, because like yes, like policy, and that's what we're here for too, is like policy, but for people who kind of need that immediate assistance, what can we do?
So this is a big struggle. I mean, there's other medications, insulin's a big one. I know, I feel like my parents are a real benefit that my mom's controlled her diabetes without ever having to even take, even the over counter, or not over the counter, but the pill medications and everything. The fact, but I know people who have diabetes that they're spending $1,600 a month plus on insulin. It's expensive. The big advocacy is, and this is where I get into like the frustration of the healthcare system, is we need better prices. And until the government really puts I hate to say it like this, but it puts a smackdown on the pharmaceutical companies and says, you just can't charge this. This is not going to happen. That's where the challenge is. And so, I know I don't know the insulin stuff in terms of if there's financial help out there for people as well. I know when it comes to like cancer treatments and all that kind of stuff, there are groups, nonprofits that will actually help pay for cancer treatments in different areas. I would assume that there's probably some assistance available for individuals who really struggle to pay for insulin. The problem is, I think we're talking about a high number of people. And so maybe qualifying for that and the challenge usually is the people who need the assistance. And this is across the board, even when it comes to like SNAP benefits and WIC benefits and all of these things, is the people who tend to need the assistance in all these areas don't have time to take off work to go and fill out the necessary paperwork. They don't necessarily have access to the internet. They don't have access to maybe, again, transportation. They don't know exactly where to go. And so I know one of the things that organizations and health departments, some of the ones that I've worked with, are really trying to focus on is to create a database of some kind of, if your organization helps with this, and get a list of all the organizations that help. I mean, if you're within a community and you're looking for that, that's kind of an important thing, and saying so that you have like a piece of paper that legitimately says, hey, you know what, client, if you're struggling in these areas as it pertains to social determinants, here are all of the different organizations that might be able to help you, with phone numbers, with locations, with websites if they do have access. One of the things that we talk about in areas of low income is that public libraries have to be a resource. They have to have computers available. They have to have internet available, and they probably need to have longer hours because they need to have people available for, after work hours and different things. And so it becomes this really big idea that we really need a lot of resources to come together, and we need a lot of people to come together in order to do that. So I would challenge you to work, if you're in a community, to try to start building a coalition, to try to start building even a resource guide for your own clients of, if you're struggling with, paying your rent, paying your utilities, paying for this, paying for that, here are some options for you. And it's nothing, and we have to remove the stigma, because you have to imagine, I mean, you all work with clientele, some of you probably work with clientele who are getting SNAP benefits or WIC benefits, that sometimes there's shame attached to that, right? I mean, that's the reason it went from like literal food stamps, like stamps, to what looks like a debit card, right? I mean, it was because there was a shame attached to it, and people didn't want to be told, oh, like, let me get your actual stamps out, right? I remember as a kid seeing other people thinking like, I don't understand what that looks like, kind of like, I don't understand what that is. And then you know, much later after getting educated going, oh, and understanding there's a stigma attached to that. And so, I mean, I talked to some people who their food bank is doing the vouchers at the local supermarket, and there was a little bit of anxiety of switching to that format during COVID, because if people find out that this voucher is the equivalent of the food bank, is that going to bring a stigma that, oh my gosh, this person needed help because they can't afford it on their own. And so it's something that we have to remove some of the, you know, we talk about having to remove stigma from like mental health, and removing the stigma from poverty has to be a part of this as well. And understanding that people need help. And oftentimes it's factors out of their own control.
So I'm wondering if you have a perspective on how we can address, like at a policy level, that like this burden of, you know, making more money and losing a disproportionate amount of benefits that comes with an increase in wages.
So anytime you're talking about major policy as it relates to wages and benefits, obviously is an advocacy policy through your government officials. I mean, there's just no way around it. You know, the frustration, I don't disagree that our minimum wage needs to be increased. It's not a living wage. It's not close to a living wage. When 40% of your population is considered low income, you know, these are not individuals that are working part-time jobs to just like scrape by. These are not the college kids that are like, I'm just going to make my $8,000 a year and just, you know, whatever. Like these are individuals, you know, when you're talking poverty line at, what is it, just under $13,000 for a single person, 24-ish, 25-ish for a family of four, you know, and then to 200% of that. So you're not talking about this extremely large amount of money that we're talking, you know, but when you raise that minimum wage, the part that I worry is that there's going to have to be some policy in place that says, but because we're raising your minimum wage to whatever, $15 or whatever it is, and we're doing it staggered over years, that also doesn't mean that all of you individuals who were considered full-time, all of a sudden we're only going to schedule you for 38 hours, right? So there's actually going to have to be multiple levels in that policy. And the struggle with that is oftentimes we don't understand that until a policy gets put in place. So everybody gets excited about something like $15 minimum wage. Hey, yeah, that's great. Except for now we're talking about the bottom line. And so then the bottom line, what that becomes is, well, 90% of our employees are going to work no more than 38 hours or 36 hours, kind of depends on where you live, but so that we don't have to pay those benefits. And so then all of a sudden what happens is our number of individuals who are insured starts to go down, right? Which is what the Affordable Care Act was trying to at least make a dent in and did. You know, whether you liked the Affordable Care Act or not, it made a dent in that. There are other problems with it, but there's always problems with plans, right? It's kind of like education plans always have problems. Healthcare plans always have problems because no one's ever completely happy. So, yeah. So, I mean, the big thing is really, you know, you guys, I kind of came in, about 15 minutes into your earlier conversation, and you all were talking a little bit about advocacy and how to be an advocate. And I would say if you as a dietitian are not currently working in conjunction to some degree with your health department, and other people who work in the public health realm in terms of like nonprofits and different things, those are also the people you need to talk with because they typically have a strong voice as well. And so figure out how you can, I mean, the idea of a coalition is just so important because you've got like-minded people all trying to work in conjunction together and use each other's resources. You know, as an individual, if you're a dietitian who sees private clients or has a clientele where you're not really, you know, you're kind of working as a self-employed or even, you know, different areas, you may or may not work with your health department. but you need to understand what they're advocating for as well, because they're a key advocacy role when it comes to nutrition in the state level, right? I mean, especially if you're talking about the state level, and then hopefully in the federal level, and then the states, hopefully partner together, but especially at the state level. I mean, the idea of, reducing taxes on food, on having more opportunity for policy in different areas that surrounds food. I mean, so we have a group of individuals who are trying to hack the school food system, right? I mean, that's what we're also looking at that right now. And so you have to advocate, and you can be loud about it, and you can be annoying about it, and you can, and you go, if I send a letter every week, it's so, but eventually somebody listens. Eventually, it's so frustrating though. It can be so frustrating. I think Carol was the one who was talking about, seeing some of her local politicians just in the neighborhood, and you're like, I would love that. I would say, find them, hunt them down. Don't be a stalker though. It's weird.
I think that's like a super great perspective. I do want to check in with you really quickly. Do you have more presentation, or do you want more questions?
I want to cover one more. I mean, I have more presentation. I had a feeling I had too much. I was nervous about it. Health disparity is just something to think about, right? I mean, these are just like some facts. I can leave these up and I mean, I'm going to just live it so you guys can read them real quick. We talk about things, and I had some from that as it pertains to like food and stuff, but these are just like overall some health disparities, because that social determinants actually lead to this. And a lot of times the racial groups and minority groups are kind of a problematic, but it also, we're talking about anything that has historically linked to discrimination or inclusion. So race and ethnicity, religion, SES status, gender, disability, mental health, sexual orientation. Geographic location is actually a really interesting one. So the Robert Wood Johnson Foundation did a study looking at life expectancy in general areas. There's a area in Kansas City, Missouri that is 3 miles apart, not 3 blocks, 3 miles apart, that the difference in life expectancy is 14 years.
Whoa.
There's the difference between urban New Orleans and suburban New Orleans is 25 years. Life expectancy, for all these reasons we talked about, right? It's not just one particular, it's because minority groups that live in the area. It could be because the neighborhoods are unsafe. It could be because of access to healthcare or quality healthcare, all of this stuff. And so it's something to consider. So all of these factors go into these health disparities. And I kind of just wanted to throw some of those out but we're going to be pressed for time. So the last thing I really, really, really wanted to talk about was this health impact period. I don't know if you guys have seen this. This is a framework that's been around in public health for quite a bit. And so it's something we have to consider, because if you look at these 5 areas that we think about, and public health really focuses on all of it, except for medical care. I mean, we do a little bit when it comes to medical care, but that's not, I mean, it's about making sure people have quality medical care and access to medical care more than the actual care itself. So when you think about this, the closer you get to the base of the pyramid in these areas, what happens is it's the greater impact you have on number of people. So if we can do things like controlling some of the socioeconomic factors, increasing access for healthy foods, increasing or decreasing costs as it relates to housing, increasing green space areas, all of these built environment or social environment factors, we can actually affect the greatest number of people. But as we go up higher, it requires the individual effort. And that's where we start having to think about all these factors and how it affects somebody's motivation. So when we're talking about counseling and education, which is a lot of what you all do, it really does require a lot of effort of the individual coming to you. And so the impact is on one person or a single family unit, versus if we start focusing on some of these other issues, we can have a greater impact across the board. And it's not saying that what we do here, right at the top with counseling and education isn't important, because it's absolutely important. But we have to remember that all of these other levels have to play a role so that when we do the counseling and education, the effort is lessened, right? We want to make their effort to make these decisions as little as possible, right? We want it to make them default. We want those default decisions and things like that. So I just wanted to cover that. I can more than happy to do, I had a little bit on policy, but I'm good. You guys can ask me questions. I'll see if I can answer them. No guarantees.
Awesome. Well, let's go ahead and open up the floor for questions. If you have a question, you can either type it in the chat or feel free to unmute.
Oh, I do like this. That's what we change it to, right? We want justice. We want everybody to have equal access.
So I have a question, Dr. Holt. My
Sure.
name is Christy. Given everything you've shared, all the determinants that you shared,
Mhm.
and I know we're coming from the dietitian perspective, but really any provider of any kind working with patients, families, clients that are experiencing all of the complexities that you have mentioned.
Mhm.
I know you've said things like advocate. What are some other key points you would have a provider, someone providing support, care, what have you, keep in mind when working with families of all these different complexities?
I think one of the things that is really important when we're working with families that have this is understanding no family is the same, and not assuming that, you have two people that, they could be neighbors and their family situation is going to be different, and truly trying to understand. So one of the things, and I kind of took this from a previous colleague of mine, I used to say it all the time, is we cannot serve our people if we don't understand our people. And so he always told our students to think of it this way, is first understand, then be understood, right? So until we truly understand who our clientele is that we're working with, and we understand what resources we can help provide them. So, one of the things that I think that, I don't want to say dietitians do, but I think when we get into our silos of what our professions are, is that we tend to forget that we can actually help provide resources in other ways, that we don't think about the fact that maybe if I have a client who says, transportation's really hard for me, that I can say, okay, here is a list of resources that are available to help you with that. Or if they say, you're asking me to go spend a lot of money on food that I don't have the money for because I'm trying to keep my lights on, here's resources that can help you with that, and actually look at that. So interestingly, there was a hospital in, I want to say it was in Boston. It was a few years ago. I heard this story and read about it a little bit. I think it was in Boston, that actually had patient advocacy days where they invited social services into their hospital, like lobby area, and they'd have clients that would come in, or patients that would come in that, maybe weren't following their medication protocol, or they needed help with different things. And so when the person came in and they said, you're expecting me to take this medication that I can't afford because I have to be able to keep my lights on, or I have to be able to do these things, they say, okay, I need you to go talk to that person right over there and get set up with that service. And then they, so they could just bounce around. And so that's something for, communities to think about. Is there a way that we can bring services to the people who are in the most need for it in a way to where we can provide those services all in a singular place? I think that's really important. I found that to be extremely interesting case. And what they found was that the people who participated in those days actually started to follow their protocols a little bit better, and were able to, had better health outcomes at the end. So I think one of the things that we have to maybe can remind ourselves regularly is that we don't have to live in a silo. We don't have to only think about how we can be effective in this one area, that how can we be, I mean, simply a one-on-one patient advocate and help them find the resources that they need. I think educating yourself on the resources in your community is super, super valuable.
One thing that I learned about during my internship, which I'm currently in, is non-compliance. When you talk about your patients being non-compliant, and I read about a different perspective on that, and it said, you know, instead of just labeling your patient as non-compliant, looking closer into, well, why is that? What are the factors at play that is making the patient non-compliant? It's not that they're not wanting to comply, but maybe that they're not able to.
Mm-hmm. Yeah. And we talk about that a lot, right? So I talk about that. It's interesting because in our 2 programs that we have from our students, right, we have the public health students and we have the exercise science students who want to go on and maybe work with, and some of them, you know, may go on and become dietitians. We have some that really, you know, Kelly's been very influential over some of them. And then we have some who want to go on physical therapy, you know, occupational therapy, this. And we talk about the clientele and saying, you know, you could have 3 clients that all, let's say from a physical therapy standpoint, all had knee replacement on the same day. Let's say they're 58 years old and they all had a knee replacement on the same day. And you've got one who's healing fantastically. You have one that's doing okay. And you have one that's, as you say, non-compliant. And it's really, what are the factors here that are playing a role in this? And you have one who is, you know, had this high paying job, educated, et cetera, who's now retired. You have one that might be still working regularly, and you have one that may or may not have insurance and can't actually come in for physical therapy. And so you don't know what you don't know until you ask those questions. And so that's why it's that idea of understand your client before, it's that understand them before you start, you know, saying this is how we can fix. You know, it's really important to understand the challenges they're truly facing. And I always think of it too is we don't know if they, and then so sometimes you have to build that trust with them because they're going to have to divulge a lot of information. It's interesting when you work with people with physical activity, and you guys probably get this, is after you kind of build a repertoire with your clientele, the next thing you know is you become this counselor that in areas you never thought you'd become a counselor in. You know, when you personal train and you've got someone and you start them warming up on a treadmill and all of a sudden they're in tears and you're like, I just asked you to walk for 5 minutes before we did anything else, and they're in tears, and it's because of the day they had or something that's going on in their life. And you have to say, maybe today isn't about the physical activity. I mean, still let them be physical, but maybe it's not about the workout I've created. Maybe it's about, let's move a little, let's de-stress. And it's more about the support you can give them in that moment. So I think it's picking and choosing and thinking about where they're coming from in that moment, which is going to be different every single time you see them.
Right. Well, thank you so much, Dr. Holt. And we're going to go ahead and wrap it up so we can take a tiny break. But I think that was super insightful. And I hope everyone found some value in that and how we can, you know, focus on things that we're doing specifically with our patients. And then also how, you know, we've highlighted some of these greater changes that need to happen on a policy level. And if you guys are interested in getting involved, please reach out to our advocacy team. I know we talked about licensure at the beginning, but we really do touch so many other areas of advocacy, from food security, malnutrition, insurance, and things like that. So if you're interested in any of that, please feel free to reach out to me. But thank you so much, Dr. Holt. And we're gonna go into a quick 3-minute break so you can run to the bathroom, get a drink, and then we'll start our presentation with Representative Haswood.